Thank you, Shushmita, respected chair and co-chair and your co-presenters in the dais and respected audiences. Very good afternoon and assalamu alaikum and namaskar. I am Dipika from Ipas, Bangladesh, going to share some innovations of Ipas, Bangladesh. You all are know that. Oh, next slide. Oh, sorry. Ipas Bangladesh is working in Bangladesh since 2011, and we are working to strengthen the health system blocks for sustainable AP, that is family planning, MR, and post-abortion care services. For sustainable family planning, MR, and post-abortion care services in rural, urban, and humanitarian settings. And IPAS is working in collaboration with DGHS, that is Director General of Health Services, Director General of Family Planning, Director General of Nursing and Midwifery of Ministry of Health and Family Welfare, and other ministries and key stakeholders. And we are aiming to strengthen facility readiness, improve the facility readiness, and building the capacity of health workforce so that they can provide the quality AP, MR, and post-abortion care services. And IPAS also provide support for strengthening health information system with standard and uniform SRHR indicators so that national level and local level policymakers and stakeholders can use the data. And also work for strengthening logistical management information system for uninterrupted supplies of reproductive commodities. We are also working at the community to improve the knowledge, care sharing, and social support related to sexual and reproductive health services. And finally, also IPAS conduct advocacy and provide support to at the national level based on the evidence-based intervention and protocols to make in the national change in the national level policies. Policies. Now I am going to discuss about the innovations. IPAS build capacity in 2 ways, that is in-service training and pre-service training. And in this slide, we can see the in-service training, competency in-service training model. Okay, in this slide, we can see the in-service competency-based training. And the first is we select trainee in consultation with DGHS and DJP, and then our trainers provide competency-based training on FPMR and PAC services, and this training duration varies from 2 days to 14 days. And innovation is that after the training, we continue the follow-up with the trainees, either phone call or facility visits, and provide need-based mentoring support to improve their competency and ensure the competency to provide a PMR and post-abortion care services. In last 5 years, IPAS built capacity of 3,609 service providers, which include 1,590 doctors, 1,684 midwives, and 237 FWPs. And as a result, by these 10 providers, more than 2 million family planning service has been provided from 500 facilities, which include post-abortion family planning, postpartum family planning, and general family planning service, and also 1,24,000 MR service and 1,51,000 post-abortion care services. This slide shows the pre-service competency-based training model for intern doctors. And for intern doctors, IPAS conduct advocacy with the academicians of the medical college hospitals for importance of this training, and then conduct the duty with the academicians and supervisors of the intern doctor and establish a skill level in the medical college hospital. And then select trainee from the batch who are currently deployed in the OBGYN department, and then provide competency-based training to them, and similar to in-service training, continue the mentoring support to them to ensure their competency. This is another pre-service competency-based training for midwifery student, and I was implementing this pre-service competency-based training in 15 nursing colleges and institutes of midwifery diploma and post-basic courses, and we follow 3 steps. At the first steps in the nursing institute, we establish skill lab and establish teaching standards for faculty and provide training to the instructors for 14 days to build their capacity and continue maintaining support to them. And then the primary first year and second year students placed in the primary clinical site for practical sessions, and which helps them to improve their competency and establish linkage between instructor and the clinical attachments. And the final year students, that is third year midwifery students, placed in the midwifery late care, that is Upajala Health Complex, for practical training. And this slide shows the achievements. We implemented the midwifery project in 50 Upajala health complexes, and this slide shows the achievements, that is performance by midwives. হ্যাঁ ল্যাপটপ দিয়ে করব
হ্যাঁ আপনি প্রেজেন্ট করতে থাকেন ল্যাপটপ থেকে আপা
আচ্ছা ঠিক আছে থ্যাংক ইউ and
we are at the strengthening HMIS systems to ensure quality SRH services slide. আপনি প্রেজেন্ট করতে থাকেন, I'll change it from here.
Okay. Thank you. Now I can see the screen also. And Ipas provided support for strengthening health information system of DGHS, and actually conducted advocacy and with DGHS, DJP and other key stakeholders to develop a single register for family planning services and develop this family planning register, and now currently it is used by all the DGHS facilities. And we also provided technical support to update the MR and post-abortion care registers with the standard indicator, for example, including the MRM information and gestational age information like this. And this register is used by all the DGHS facility, and currently it is piloting, is ongoing in some DJP facilities. That number is 137. Ipas also conducted advocacy and provide technical support to develop to incorporate the family planning and MR and post-abortion care database in the DHIS2 of DGHS, and developed dashboard for both family planning service and MR and post-abortion care service, where data can be used, real-time data can be used, and this data can be used by the national level and local level stakeholders for improvement of the SRS services. And for the strengthening the logistical management information system to ensure the uninterrupted supply of essential reproductive commodities, we closely worked with Digi Family Planning, Digi Ages and private and urban health facilities, and as a result of advocacy and support, a total of 144 DGHS facilities and some private health facilities came under the supply chain management portal, and working as SDP and directly receiving family planning service, including the long-acting and reversible contraceptive services from DJP to ensure the quality family planning service in the facility. And also Ipas work in the community to improve knowledge, care seeking and social support in rural areas, urban areas, as well as in the humanitarian setting. And we demonstrated in rural areas, we supported 17 community radio stations and provided training and orientation to field workers like family welfare assistant, health assistant, community health care providers, and organized street drama programming in some upajalas, and also developed some SBC materials, for example, some posters for specific family planning methods. In urban areas, I was supported 57 Ipas Bill 57 community action groups that consist of 10 community volunteers, including youth and adolescents for community mobilization for SRHR. And in humanitarian setting, out of 34 camps, Ipas is working in 25 camps for social mobilization, especially to reduce the religious barriers by engaging imam through Islamic Foundation. And this slide shows the policy level changes, and Ipas conducted advocacy and provide support for this policy level changes. In 2013, the nurses allowed to provide MR and post-abortion care services. In 2014, MR by medication has introduced in national program, and 2015, MR service expanded by mid-level providers within 10 weeks and by doctors within 12 weeks. And in 2016, MR service included in the ESP of the Ministry of Health and Family Welfare, and in 17, MOSW developed a costed plan for procure manual become aspirated plus for MR and post-abortion care services. And in 2028, midwives allowed to provide MR and post-abortion care services. And 2000, I need 3 more minutes. And in 2019, paramedic allowed to provide post-abortion care services. And in 2022, AP dashboard, AP and database that was developed in DHIS 2. Can Our next innovation is ward model. We are actually demonstrating this model in urban areas for SRHR services. In this model, in each ward we know there is a urban primary supported NGO clinic, that is CRCC or PSCC, and also there are some outreach worker, but still there are some gap to cover the full ward, and we train 3 to 4 general practitioners in his ward and involve and develop a community support group involving volunteers so that they can conduct social mobilization and refer clients to GP and the CRCC also. Ipas also use VCAT training, values clarification, and attitude transformation training for stigma reduction. We implement VCAT training national and district level as well as facility level. And for reduction of reproductive cohesion and gender-based violence, Ipas generated evidence by adopting and testing the effectiveness of artist intervention that is originally developed in the USA for family planning clients, and we okay, thank you. And this model has 3 core strategies to provide universal counseling to all women who are coming to the facility for family planning or abortion services, and create an environment for disclosing RC and IPB, and distribute the takeaway materials like booklet, and which actually generate evidence to increase reproductive autonomy and as well as decrease the GPP. And this slide shows the results from one art city which we implemented in urban Bangladesh, and we can see in terms the use of modern contraceptive method 1.58 times higher odds than control area after 3 months follow-up, and after 12 months follow-up it remains 1.48 times higher. And in the humanitarian setting, we also adopted this model, and we can see the increase in the self-efficacy of AP increased by 62% from baseline to exit, and 92% from baseline to 30 days follow-up, and self-efficacy for IPP support services also increased by 70% after 30 days follow-up, and attitude about RC also increased by 109% from baseline to 30 days follow-up. So that's all. Thank you.